Yeah, yes, macular hole.
Uh, a very good afternoon.
Shows
And
the video only.
yeah, so there are various advancements since the concept of macular hole surgery was first described. And conventional ILM peeling is good for small holes. But when it comes to large or extra large holes ranging between 400 to 800 microns, that's the minimum linear diameter, ILM flaps give far superior results. Although it can be used as a primary technique in holes which are larger than 800, but there are chances of failure. So, when to choose ILM flaps when we have patients like these, that is 400 to 800 microns, and best if they have a raised cuff. Um, Also, we will not choose
So best
for.
indication, Sneha, is whenever height is less than the width. That is the best, I think, practical scenario.
Hmm.
जब height कम है और base ज़्यादा है, always choose flap.
Yeah. And the second one, where we have a very large hole and there's a flat dehydrated edge, then we are going to go for grafts. So not only just large macular holes, but the ILM flap technique, it does improve the surgical success in traumatic, myopic macular holes and macular holes with RD. So before coming to the peeling, there are a few things that we have to keep in mind. Number one is double check the PVD, if necessary with tricot. As in this case, where I had done a PVD induction and also done half the peeling, but then still I ended up with a full sheet of vitreous attached to the posterior pole, as these cases can have vitreoskisis. Also, next up is the staining. I usually stain under infusion with brilliant blue. So if the staining is inadequate, there is no harm in going back and re-injecting the dye to get a better contrast. Also, to avoid jet stream injury, the first push has to be either on the disc or on the light pipe, and then once we get a good flow, then we can inject all around the macular hole, avoiding direct injection into the hole. So there are various instruments that can be used to raise the edge, but the pinch and peel technique using the ILM forceps is the most atraumatic. So what we do is multiple pinches and releases just to loosen the ILM and to pick it up, and once that ILM is loose enough, then we can go ahead and do the peel. The trick to get a very large area peeled, because we want to get a large area peeled in the first go, is that we can have the edge has to be longer. So if we have this size of the edge, the peeled area is that. Then again, if we have that edge, the peel area is bigger. So the peeling has to be in a circumferential manner. The flap is held at the most distal part and is peeled, grasping the flap along the peel, and the direction has to be towards the fovea. Also, I prefer a larger peel, that is around 2 disc diameters for larger holes. So slight amount of ooze is fine with while peeling, but if there is a trauma and you end up with a good amount of bleeding, then what we can do is just raise the IOP. So the ILM is peeled all around the hole except the first for just 2 or 3 quadrants, which is used as the flap to invert over the hole. Both a superior hinged as well as a temporal hinged flap is a good option. While making the flap, instead of peeling the ILM of the hinge flap right up to the hole, as you can see in the second case, if you just leave a small margin there, that extra attachment will give better control during the flap manipulations, like trimming or even placing the flap on the hole. Also, to avoid the entire flap to be suctioned into the cutter, what we can see is the vacuum is kept to the lowest and the cut rates are high. Also, the flap has to be adequately sized. It should not be too big. It should be just enough to cover the hole. So usually we prefer a single flap to cover the macular holes, but there are techniques like the multiple layered flaps, where multiple layers of ILM are placed over large macular hole, and this gives a better closure rate, but there are also chances of gliosis. There's another technique where we have a temporal hinged flap, but then we leave the papillomacular bundle intact, the ILM of the papillomacular bundle intact. This basically has lesser of the nuclear layer disruptions. So instead of tucking the ILM flap, it's obviously better to just place it over the hole. Better anatomical results are achieved with this. With fluid air exchange, what I do is first take out maximum of the fluid with the cutter. But to avoid excessive suction on the ILM, the cutter has to be placed on the disc and the port has to be away from the hole. The last few drops are removed via passive suction using a soft tip. Another tip here is to just momentarily increase the IOP during the last reaspiration. What it does is the few drops of BSS which are there in the infusion tip, it just trickles down the retina and then you can just remove that. So I prefer a C3F8 gas rather than air on face down position for 1 to 3 days depending upon the size of the hole. What do we do when we have a ERM which we cannot use as a flap obviously, or we have a flap loss accidentally? We can use a free flap which is harvested from the temporal macula, and that is what I do is basically the peeling, it's half peeled under infusion, and then after the PFCL is injected, then the peel is finished and it is transferred very slowly over the macular hole. Also, a drop of viscoelastics can be used just to keep that flap in place. So regarding macular holes with RD, it is challenging because of the retinal mobility, where the PFCL does a good job in not only reducing the mobility of the retina but also giving a counter traction for the peeling. Although the peeling can very well be done under infusion, the basic principles are the same. Also, I will say that if we start the peeling in the nasal part of the retina, the inferonasal part, that gives a slightly better traction because of the attachment with the optic disc.
Sneha, can you conclude now? Because
Yeah. So just with the macular holes with RD, never aspirate through the macular hole, always through either drainage retinotomy or the primary break. And just for myopic macular holes, the basic thing is that you need to re-inject the dye as the contrast is less. Also, finesse loop here works very well because it gives an extra length for you to raise the edge, and also the use of contact macular lenses, as these can really enhance the view of your macula. That will be it. Thank you.
I think we'll conclude. Yeah. Chal, thanks.